So we
Yeah, I am ready. Hello. 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 Any problem? Yes, yes, but I don't know. Its time is up, but no one is telling me to start. Okay, okay. Then until I get her call, I'm waiting. Okay, thank you. Thank you.
Sir, am I audible to you?
Yeah, I'm audible. You're audible? Am I audible?
Yes, yes, sir, you're also audible. So with all your due permission, sir, we are beginning with the session for today.
Yes.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With great honor and with great pleasure, I would like to introduce our keynote speaker, Doctor, for today's session, and he is none other than Dr. Shankha Sen, sir, who is a very renowned diabetologist. Sir is MBBS gold medalist, MD in General Medicine gold medalist, FACP, FICP, FIAMS, FIMSA, FIACM, FISHF Diabetes India, and consultant physician and practicing at Siliguri, West Bengal. With the help of sir, we'll be taking a close look on today's topic, which is subclinical hypothyroidism. Before moving on to today's session, let us have a brief look on what the topic says. Normal levels of thyroxine and increased levels of thyroid stimulating hormone are typical signs of subclinical hypothyroidism. It is observed in 3 to 15% of people, and the fact that each person's hypothalamic pituitary axis has a different personal set point is the secondary cause of the little intra-individual variance in TSH levels. We'll be learning more about subclinical hypothyroidism with Sir's wonderful inputs about the topic and his knowledge. So now, without any further delay, we would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you for your kind introduction. At the outset, I welcome you all for this scientific session, a webinar on subclinical hypothyroidism. I am Dr. Shankha Sen, a practicing physician from Siliguri. I will be highlighting few points on this particular topic. And I thank IGCP MedTalks for giving me this opportunity. So my talk will be on subclinical hypothyroidism And I will start with a case. A 25-year-old male, engineer by profession, is complaining of lethargy, no family history of thyroid disease, family history of coronary artery disease is there. There is no goiter, but the TSH is a bit high, between 7.8 milli unit per liter, and the FT4 is 1.01, which is quite normal. What we should do? These are certain cases where there is no not frank hypothyroidism or overt hypothyroidism, but definitely the symptoms of fatigue is there and lethargy is there. The patient has a family history of coronary artery disease with a normal FT4 but a high TSH. So what we should do? So that will be our point of discussion today. So we'll be discussing about what is subclinical hypothyroidism, what are the consequences of subclinical hypothyroidism, effect of thyroid hormone replacement if and when needed, and certain management issues, whom to treat, whether to treat or not, and how to treat. So just to cap up that what we should know and what you already know about hypothyroidism, the types are, as we all know, a primary hypothyroidism, which is due to thyroid destruction. Thyroid organ, the thyroid gland produces less amount of levothyroxine. Similarly, central or secondary hypothyroidism, which is due to deficiency in TSH secretion from the pituitary, generally due to cellular lesions such as pituitary tumor or craniopharyngioma, and it is infrequently congenital. So the third one is a central hypothyroidism or tertiary hypothyroidism. Now, congenital hypothyroidism can be there due to agenesis of the thyroid gland and defective thyroid hormone biosynthesis due to enzymatic defect, and thyroid tissue destruction as a result of chronic autoimmune Hashimoto's thyroiditis is the most common form of hypothyroidism, and that is very important because we usually treat that. It can be due to radiation, it can be due to thyroidectomy, there can be thyroid tissue destruction, and ultimately we get overt hypothyroidism also. Drugs like with antithyroid actions like lithium, iodine-containing drugs, radiographic contrast agents, interferon alpha, all can lead to destruction of the thyroid gland. So hypothyroidism is usually due to the chronic autoimmune Hashimoto's thyroiditis. So the clinical spectrum ranges from subclinical hypothyroidism to overt hypothyroidism, and ultimately it can be such high levels of TSH and low levels of FT4 and FT3 that it can cause myxedema coma. The clinical features of hypothyroidism include tiredness, forgetfulness, slowness in thinking, irritability, depression, inability to concentrate, thinning of hair, hair loss, loss of body hair, dry patchy skin. There is commonly we get weight gain, cold intolerance, elevated levels of cholesterol, and family history can be there. There can be puffiness of the eyes, enlargement of the thyroid in the form of goiter, hoarseness or deepening of voice, which is quite common, persistent dry or sore throat, difficulty in deglutition or swallowing. We can have a bradycardia, that is a slow heart rate. There can be menstrual irregularities in females with infertility in both male and female. Constipation, muscle cramps are all very common features. So thyroid presents with hypothyroidism presents with varied clinical symptoms and signs, and that is very important we can diagnose. But what to do with subclinical hypothyroidism? Usually symptoms are very less. Most of the symptoms are not present, but on checkup we get, when tested, the blood test revealed of a normal level of FT4, but with a high TSH. So what is subclinical hypothyroidism? Eventually, biochemical definitions are normal FT4 with an elevated TSH, and the causes are similar to that of overt hypothyroidism as I described, and the overall prevalence in India is around 8%. To define it, it should be around 12 weeks or longer with an elevated, persistently high TSH level of more than 4.5 or 5, with normal free T4 and T3 levels after repeated measurements, and with few or no signs and symptoms of hypothyroidism. So in subclinical hypothyroidism, with these biochemical values, there can be few symptoms or even no symptoms or signs of hypothyroidism. So patients with subclinical hypothyroidism again can be categorized with mildly elevated TSH with a normal FT4, FT3, that is between 4.5 to 10, or a markedly elevated TSH of more than 10, but the FT4 and FT3 are normal. So the level of TSH is very important, and in that way we can decide how to treat, and that will be some of my points which I'm going to discuss in my next few minutes. Regarding overt hypothyroidism, as I have shown you that there is florid clinical picture. There will be decrease in the level of FT4 and free T3 also with an elevated TSH. Usually that level becomes more than 10. But in subclinical hypothyroidism, the normal FT4 and FT3 with few or no clinical signs differentiates both of them. Regarding epidemiology, it's important because why are we discussing it today in India? There have been studies like epidemiology of subclinical hypothyroidism in India that the percentage of the prevalence has been found to be quite important. So the latest ones with Unnikrishnan et al. From 2013 showed there is a prevalence of around 8% in India. Similarly, there are multiple studies. In 2012, one study showed that the prevalence was around 19.3%. It was by Marwa et al. Similarly, there are multiple studies, and the prevalence of hypothyroidism in adults was studied in 8 cities across India in 2013, and it was published in Indian Journal of Endocrinology and Metabolism. It showed that in our state of West Bengal, the Kolkata had a high statistics of presenting with subclinical hypothyroidism of around 11.8%. Other cities which are studied among these 8 cities, after Kolkata, there were high prevalence in Delhi, around 9.6, 7.27 in Bangalore, 7.16 in Ahmedabad, Hyderabad was 7.3%. The least in this category was in Chennai, around 5.35%, and Goa 4.23. So the subclinical hypothyroidism is quite prevalent, but it varies from city to city. And the prevalence of overall study population was around 10.95%. Cities located in the inland regions of India, that is Delhi, Ahmedabad, Kolkata, Bangalore, and Hyderabad, reportedly a significantly higher incidence, higher prevalence compared to Mumbai, Chennai, Goa, or in the coastal areas. So it was between 11.73% of the inland regions compared to the coastal regions, around 9.45%. And women were 3 times more likely to be affected by hypothyroidism than men. That is, in this study, 15.8% of women and 5.2% of male were affected. Regarding the prevalence, it increases with increasing age, and the incidence increases around 2.1 to 3.8% per year in thyroid antibody positive patients and 0.3% per year in thyroid antibody negative patients. So the subclinical hypothyroidism is something where the symptoms are less or few, and overt hypothyroidism is something where the symptoms are florid with less levels of free T4 and free T3 hormones. So the studies showed that with a high incidence of anti-TPO was also present in certain cases, and they were having more incidence of not only subclinical but also overt hypothyroidism. Now, the progression was found to have that annual rate of progression to overt hypothyroidism ranged from 2 to 4%, and the risk of progression is high with higher TSH levels. Like if the TSH is more than 12 to 15, if there is positive anti-thyroperoxidase antibody, high levels of therapeutic external radiotherapy, the risk of progression is more, and the TSH levels become normal without treatment in 62% of patients over 5 years. So that is also quite important. So these are the areas we need to discuss whether they need to be treated or not, and we should be careful regarding whom to start treatment and whom doesn't need treatment. And as time goes on, from the severity of normal from euthyroidism to subclinical hypothyroidism in this particular level, and ultimately when the TSH goes on increasing, ultimately the T4 and the T3 goes on decreasing, in certain percentage of patients, these subclinical hypothyroid patients will definitely progress to overt hypothyroidism. So the TSH rises fast and abruptly. Decline of T4 and T3 is slower and later, and from euthyroid to mild thyroid failure, there can be overt hypothyroidism as years progresses. So the natural course of the syndrome during a prolonged follow-up study has been found that 50% of subjects in 1993, it was 30 years, almost 30 years back, it showed that 50% of subjects developed definitive primary hypothyroidism within 2 years. So in those days, even the studies showed that it was a relentless progression in most cases. So subclinical hypothyroidism is mild thyroid failure, and it should be treated. It should whether it should be treated. The progression has in fact been reported to occur in approximately 3 to even 18% of affected patients per year. So the clinical presentations which are found in those cases, the results of a study on subclinical in 237 of patients in 2013, almost 10 years back. The most common symptoms were weight gain in around 62% of patients, fatigue in around 69% of patients, lethargy in 63% of patients, and dry hair or alopecia in 55.4% of patients. So these are the common symptoms of hypothyroidism and which are commonly found in subclinical hypothyroidism patients also. The exogenous factors are under replacement of levothyroxine, medications such as I mentioned, like lithium, iodine-containing agents like amiodarone, which is commonly used in cardiac patients, and in antithyroid medications, whether there is history of exposure to I-131 therapy or thyroidectomy. Similarly, endogenous factors are if there was history of previous subacute or silent thyroiditis, and also in cases of Hashimoto's thyroiditis. Now, why are we discussing this? The altered cardiac function, lipid status, and possibly cardiovascular outcomes matter. And hypothyroid symptoms and altered mood and cognitive function should be discussed, and whether it progresses to overt hypothyroidism or not. So the most important thing is in hypothyroidism is that hypothyroidism, whether overt or subclinical, can lead to a hypercoagulable state, abnormal hemodynamics, atherogenic lipid profile, and impaired endothelial function. All are high risk factors for cardiovascular disease. And there can be abnormal non-traditional risk factors like lipoprotein A, homocysteine, increased high sensitivity, CRP, LDL particle size decrease, and the remnant particles. So untreated ones and its consequences will involve changes in cardiac function, lipid profile, and possibly the cardiovascular outcomes. And the progression to overt hypothyroidism needs to be discussed. So the progression to overt hypothyroidism is around, in average, 2 to 4% per year. The cardiovascular disease is very important because the trend of increased risk of cardiovascular disease. Usually there is no direct association of stroke, but no association, but the association needs further studies. Reproductive abnormalities are definitely there, and there is increased risk of miscarriage, preeclampsia, and preterm delivery. And non-alcoholic fatty liver disease, that's the NAFLD, which is a big thing nowadays. Most of the patients suffer from fatty liver disease in spite of patient not being subjected to alcohol intake. It is associated in a dose-dependent manner. Neuropsychiatric symptoms, there are controversial regarding it, but certain neuropsychiatric symptoms are associated with hypothyroidism and sometimes with subclinical hypothyroidism is also. So, first point is coronary heart disease. There had been conflicting results from multiple observational studies, but meta-analysis of multiple studies have shown there is a significant trend of increased risk of coronary heart disease and events. The non-fatal MI, coronary heart disease death, hospitalization for angina, and need for coronary revascularization was studied. And multiple studies in last 10, 15, 20 years showed there was quite an increased risk. And to conclude, these studies, these meta-analysis showed that subclinical hypothyroidism is associated with an increased risk of CHD events and coronary heart disease mortality in those with higher TSH levels, particularly those with a TSH level of more than or equal to 10, and if untreated. Similarly, for heart failure, there was a significant trend for increased risk for heart failure at higher TSH concentrations. For strokes, however, there does not appear to be an association between subclinical hypothyroidism and risk of stroke. However, in younger patients and in those with high TSH concentration, there might be an increased risk. And all these references are from studies in the last 10, 15 years. So the other coronary risk factors include modest elevation of total cholesterol, although its clinical significance is not known. Subclinical hypothyroidism is associated with an increase in markers of inflammation, vascular reactivity, endothelial function, and carotid intima media thickness. Thyroid hormones are significantly affect the lipoprotein metabolism with varied effects on cholesterol levels, and thyroid dysfunction also predisposes to individuals to cardiovascular risk factors such as metabolism and production of adipokines, oxidative stress, and metabolic syndrome. In many cases, hypothyroidism and hypercholesterolemia do coexist. And in overt hypothyroidism, usually the levels of cholesterol like LDL increases by 30% and total cholesterol similarly, and ApoB and lipoprotein A are increased. There is no clear consensus on whether thyroid replacement therapy with levothyroxine has beneficial effects on serum lipid profile and cardiovascular disease risk in subclinical hypothyroidism patients. But thyroid substitution in patients with subclinical hypothyroidism is recommended if the serum TSH is more than 10 in patients having high initial cholesterol levels, if they are elderly, smokers, or are positive for antibody to thyroperoxidase. So replacement therapy should be started with a dose of 25 to 50 microgram per day of levothyroxine in a low dose, and it should be measured once euthyroid. It should be measured every 6 months and then annually. But if the TSH levels are between 4.5 to 10, routine treatment is not required. Monitoring should be done, and a lipid profile should be repeated after euthyroid state is achieved. Now, regarding non-alcoholic fatty liver disease, it was statistically significantly associated with hypothyroidism. And one important thing is that subclinical hypothyroidism are more likely to have common bile duct stones due to sphincter of OD dysfunction. That is one important point we should keep in mind. Now, association with depression, anxiety, or cognitive dysfunction is controversial, and subclinical hypothyroidism was associated with an increased risk of Alzheimer's disease in women, but not in men. These are the studies done in 2008. And whether women with preconceptional subclinical hypothyroidism state have decreased fertility remains uncertain, but there is an evidence that of an increased risk of miscarriage, preeclampsia, preterm delivery, and abruptio placentae in women with subclinical hypothyroidism and in euthyroid women with anti-TPO. The increased levels of estrogen in pregnancy is very important. Similar structure of HCG and TSH is important because that leads to the HCG stimulates the release of T3 and T4 with a transient TSH decrease in weeks 8 to 14. And due to increase in estrogen in pregnancy, 2 to 3-fold increase in thyroid binding globulin is there, and it decreases the free T3-4 and free T4. Similarly, the increased peripheral metabolism of T3 and T4 leads to decrease in the free T3 and T4 in pregnancy. So what are the risks? Because in hypothyroidism, as you all know, there is a fetal death, abruptio placentae, miscarriage, and preterm delivery is quite important. But we have to balance, because this subclinical hypothyroidism, if not followed up, can lead to overt hypothyroidism during pregnancy and lead to these complications. So there is a huge list of risk factors for maternal and fetal point of view, like eclampsia, preeclampsia, gestational hypertension, abruptio placentae, increased chances of cesarean delivery, preterm delivery. Similarly, long-term complications like postpartum depression, postpartum hypertension, and lactation problems occur in women. Similarly, for fetus, there can be growth restriction and impaired neuropsycho-intellectual development in after delivery, means after the birth. So these complications can be there. So in subclinical hypothyroidism, we have to be careful, and all pregnant women should be screened for thyroid function with the help of TSH as recommended by ITS and endorsed, means in the Thyroid Society, International Thyroid Society, and endorsed by the Federation of Gynecological and Obstetrics and Gynecology Society of India and the Endocrine Society of India. For newly diagnosed hypothyroid pregnant patients, initiate full replacement dose of thyroxine immediately after ruling out cardiac disorders. Those should be around 1.6 to 2.0 microgram per kg body weight, and aim is to achieve a euthyroid state as soon as possible. Previously, hypothyroid patients, when becomes pregnant, as I showed that the T3, T4 levels decrease in pregnancy, that thyroxine requirement increases by around 30% during pregnancy. So we have to adjust and increase the dose by at least 30% and adjust the dose every 4 weeks in early pregnancy, because that is the time which is very important, preferably in the first trimester, till the euthyroid state is achieved. So there is insufficient evidence to recommend for or against screening of thyroid antibodies or treating in the first trimester of pregnancy with LT4 in women with sporadic or recurrent abortion or in women undergoing IVF. But if the TSH is more than 2.5, it's quite a lower level compared to the general population, treatment is recommended. And in 20% of anti-thyroid peroxidase positive thyroid women, they will become hypothyroid as the pregnancy advances. So a proper regular follow-up is quite important. And in 20 to 55%, they will chance of developing postpartum thyroiditis is there. So the adverse fetal and maternal outcome is there if untreated, and the cutoffs of diagnosis and treatment vary from the non-pregnant, but very importantly, the monitoring should be more frequent. Even the postpartum monitoring is essential. Treatment is quite rewarding, and areas of uncertainty we need clinical judgment, and there is scope for further research. Now, in 2013, the ET guidelines said that even in the absence of symptoms, replacement therapy with levothyroxine is recommended for younger patients of less than 65 years of age with TSH of more than 10. But the ITS guidelines also said that evidence exists to recommend treatment if the TSH is more than 10 with a less FT4 or the normal FT4 or FT3. But what is important in those patients where between 4.5 to 10, we have certain issues, and the guidelines are gradually directing us to that. In last 10-15 years, there is not much advances in the changes in recommendations to treat or not to treat. Patients with symptoms of hypothyroidism, especially with fatigue, may need to be treated. Patients with high titer of antibodies or goiter, or patients with cardiovascular risk factors under the age of 65 or 70 are candidates for therapy. So what are the factors that favor levothyroxine treatment in patients with mild subclinical hypothyroidism? The therapeutic trial for clinical symptoms, it is very important. If we can help the patients in alleviating the symptoms, if there is goiter, if there is anti-thyroid antibodies, if the patient prefers to use it because of the some symptoms, if there is progressive thyroid TSH increase, if the age is less, and if there are cardiovascular risk factors or prevalent coronary artery disease, we should be careful. If there is history of dyslipidemia, smoking, and definitely in pregnancy, or the patient has some intention to be pregnant in near future. It helps in those patients also where infertility, ovulatory dysfunction is there. If the decision is to treat the subclinical hypothyroidism, then oral levothyroxine administered daily is the treatment of choice. There are evidence to support use of leothyronine, that is a T3, or combining with thyroxine leothyronine in the treatment in certain cases. So the normal dose is around 1.5 microgram to 1.6 microgram per kg per day. As I said, in pregnancy, it can be up to 2 microgram per kg per day to be initiated. But for patients with cardiac disease and in the elderly, a small dose should be started around 25 to 50 microgram per daily, and then gradually built up by 25 microgram per day every 3 weeks, if needed, till a full replacement dose, which can achieve euthyroidism, is reached. The serum TSH should be rechecked in 2 months after starting levothyroxine therapy, and the dosage adjustment made accordingly, and the target should be to keep it around 2.5. So if there is elevated TSH, we should confirm and check the FT4, TPO antibodies and lipids. If the TSH is more than 10, definitely we'll be treating. If the less than 10, if that is anti-TPO is positive, we should consider levothyroxine treatment. If that is anti-TPO negative, but there is symptoms of goiter, dyslipidemia, pregnancy, or willing to be pregnant, or anovulation, they need treatment. But usually if there is anti-TPO is negative, the elderly with no symptoms, no goiter, no dyslipidemia, then we should have a close follow-up. Similarly, the guidelines also say that we should contact, mainly if that anti-TPO is positive. In these cases of subclinical hypothyroidism, anti-TPO comes into the picture. If it is positive, we can consider treatment. But if it is more than 10, we have to treat. And if it is anti-TPO negative and the level is less than 10, we can wait and watch. But if the TSH is high or more than 10, Even if it is subclinical hypothyroidism, we might treat. So the therapy is controversial. Various guidelines have come up with various statements, but since last 10, 15 years, more or less, there is certain gray areas, but definitely we know whom to treat or not. So what are the arguments for treatment? If the TSH is more than 10, we can prevent the progression to overt hypothyroidism, and the data linking subclinical hypothyroidism with atherosclerosis and myocardial infarction. Similarly, if the TSH is 7 to 9.9, there is increased risk of cardiovascular mortality in younger individuals. And if in patients who are having TSH of between even less than 7, then the high titers of anti-TPO antibodies and patients with goiter, they need to be treated. Now, against treatment, the cost, the lifelong commitment to daily medications, and that is very important. And we have to balance between whether there is an absence of a benefit of treatment in any of the age groups. So the indications of thyroid hormone replacement in non-pregnant adults with subclinical hypothyroidism is we have to consider the patient age also. If the patient age is more than 65, we have to observe. If it is less than 65 or 70, then if there are convincing symptoms only, then we will treat. And if there are no convincing symptoms, we will observe. Like similarly, between 7 to 9.9, again, the age factors come in. But if their age is less than 65, we can treat with T4. But if it is more than 65, we have to think whether the symptoms are there or not. If the TSH is more than 10, then we have to treat. So the subclinical hypothyroidism, the normal FT4 with elevated TSH, has to summarize, and it leads to cardiovascular morbidity, non-alcoholic fatty liver disease, reproductive abnormality, as have been discussed. Treatment should be guided by possible benefit, and management in pregnancy is different, and there has a much lesser threshold. Studies have demonstrated increased risk of complications with high TSH, particularly in pregnancy. Despite limitations of available interventional trials, levothyroxine is this subclinically hypothyroid group in aggregate appeared to be suggest a benefit. So it is recommended to treat most patients of subclinical hypothyroidism with a TSH of more than 10, but those between 4.5 to 10, as I said in my previous slides, as the guidelines suggest, there can be a trial of thyroxine replacement therapy, as the case may be. Thank you for your patient hearing, and I conclude my talk here.
Thank you so much, sir. Thank you for such wonderful and comprehensive talk that you have provided to our viewers upon the topic that you have shared, and thank you so much for that. And with this, I would like to share the questions that we have received from the viewers. So with all your due permission, I would like to put it across to you, sir.
Yes.
The first question is, which abnormalities on CBC count are associated with subclinical hypothyroidism?
Usually in subclinical hypothyroidism, the CBC does not matter much.
Thank you so much, sir. Thank you for answering this question. We'll move to the next question that we have received. And the question is, which medication is the drug of choice for subclinical hypothyroidism treatment? And what are the key aspects of initiating therapy?
That has already been discussed. If we need to treat, we have to treat with levothyroxine. We have to start with the 1.5 to 1.6 microgram per kg body weight dosage. For pregnancy, it can be up to 2 microgram per kg body weight. We have to adjust the dosage by checking every 6 weeks or so, 1.5 to 2 months. And we have to go on increasing by 25 microgram of levothyroxine until we lead the euthyroid state. Once the euthyroid stage is achieved, we can check every 3 months to 6 months and follow up and adjust the dosage of levothyroxine accordingly. So levothyroxine is the only drug of choice. There is no other option.
Thank you so much, sir. Thank you for answering this question. We'll move to the next question. And the question is, why TSH is high in subclinical hypothyroidism?
So that is the pathophysiology. No, in subclinical hypothyroidism, already the hypothyroidism, we are defining it as hypothyroidism because the TSH is high. As the TSH is high, but the T3, T4 is quite normal, we are saying it is subclinical. Otherwise, if the TSH wouldn't have been high, we wouldn't have described it as hypothyroidism.
Thank you so much, sir. We will move to the next question from another viewer and the last question for today's session. The question is, what are the most common causes of hypothyroidism, and is there any link between vitamin D levels and autoimmune thyroid disease?
Yes. Most commonly, I say it is autoimmunity is the most important cause, and autoimmune hypothyroidism with Hashimoto's thyroiditis is the most common, other than like surgery, radiation, and all. And there can be even is related to vitamin D deficiency also. And since last 10-15 years, when the vitamin D concept has come up, we have multiple studies with vitamin D having multiple effects on various metabolism in our body, and hypothyroidism is one aspect of that. So patients with hypothyroidism should also be checked for vitamin D levels, and if needed, if the levels are low, if substituted, then it will also help in various autoimmune diseases, including hypothyroidism.
Thank you so much. So thank you for answering that question. It was the last question for today's session. And at the outset, I would like to thank all the viewers who have joined our platform and who were here throughout the session for this particular talk about on this particular topic, and has given their so much time and attention. So thank you to all of them. And I also hope that it is definitely going to help them in their daily clinical practices. So thank you so much to you, sir, for taking out your valuable time.
Thank you. My regards to everyone.
Thank you so much, sir. With all your last comments, sir, we can conclude the session here for today.
Yes, thank you. Thank you for the opportunity also.